10. The axial skeleton. The axial skeleton indudes the skull, vertebral column, ribs, and sternum. In general, the skeletal system develops from paraxial and lateral plate, parietal layer, mesoderm and from neural crest. Paraxial mesoderm forms a segmented series of tissue blocks on each side of the neural tube, known as somitomeres in the head region and somites from the occipital region caudally. Somites differentiate into a ventromedial part, the sderotome, and a dorsolateral part, the dermomyotome. At the end of the 4th week, sderotome cells become polymorphous and form loosely organized tissue, called mesenchyme, or embryonic connective tissue, Fig. 1. It is characteristic for mesenchymal cells to migrate and to differentiate in many ways. They may become fibroblasts, chondroblasts, or osteoblasts, bone-forming cells. The bone-forming capacity of mesenchyme is not restricted to cells of the sderotome but occurs also in the parietal layer of the lateral plate mesoderm of the body wall. This layer of mesoderm forms bones of the pelvic and shoulder girdles, limbs, and sternum. Neural crest cells in the head region also differentiate into mesenchyme and participate in formation of bones of the face and skull. The remainder of the skull is derived from occipital somites and somitomeres. In some bones, such as the flat bones of the skull, mesenchyme in the dermis differentiates directly into bone, a process known as intramembranous ossification, Fig. 2. In most bones, however, including the base of the skull and the limbs, mesenchymal cells first give rise to hyaline cartilage models, which in turn become ossifed by endochondral ossification, Fig. 10.3. The following paragraphs discuss development of the most important bony structures and some of their abnormalities. Skull. The skull can be divided into two parts, the neurocranium, which forms a protective case around the brain, and the viscera which forms the skeleton of the face. Neurocranium. The neurocranium is most conveniently divided into two portions, 1. The membranous part, consisting of flat bones, which surround the brain as a vault. 2. The cartilaginous part, or chondrocranium, which forms bones of the base of the skull. Membranous neurocranium. The membranous portion of the skull is derived from neural crest cells and paraxial mesoderm as indicated in Figure 4. Mesenchyme from these two sources invests the brain and undergoes intramembranous ossification. The result is formation of a number of flat, membranous bones that are characterized by the presence of needle-like bone spicules. These spicules progressively radiate from primary ossification centers toward the periphery, Fig. 2. With further growth during fetal and postnatal life, membranous bones enlarge by apposition of new layers on the outer surface and by simultaneous osteoclastic resorption from the inside. Newborn skull at birth. The flat bones of the skull are separated from each other by narrow seams of connective tissue, the sutures. At points where more than two bones meet, sutures are wide and are called fontanelles, Fig. 5. The most prominent of these is the anterior fontanelle, which is found where the two parietal and two frontal bones meet. Sutures and fontanelles allow the bones of the skull to overlap, molding, during birth. Soon after birth, membranous bones move back to their original positions, and the skull appears large and round. In fact, the size of the vault is large compared with the small facial region, Fig. 5b. Several sutures and fontanelles remain membranous for a considerable time after birth, which allows bones of the vault to continue to grow after birth to accommodate postnatal growth of the brain. Although a 5 to 7-year-old child has nearly all of his or her cranial capacity, some sutures remain open until adulthood. In the first few years after birth, palpation of the anterior fontanelle may give valuable information as to whether ossification of the skull is proceeding normally and whether intracranial pressure is normal. In most cases, the anterior fontanelle closes by 18 months of age, and the posterior fontanelle closes by 1 to 2 months of age. Cartilaginous neurocranium or chondrocranium. The cartilaginous neurocranium or chondrocranium of the skull initially consists of a number of separate cartilages. Those that lie in front of the rostral limit of the notochord, which ends at the level of the pituitary gland in the center of the sella turcica, are derived from neural crest cells. They form the precordial chondrocranium. Those that he posterior to this limit arise from occipital sclerotomes formed by paraxial mesoderm and form the caudal chondrocranium. The base of the skull is formed when these cartilages fuse and ossify by endochondral ossification, Figs. 3 and 6. Visceracranium. The visceracranium, which consists of the bones of the face, is formed mainly from the first two pharyngeal arches. The first arch gives rise to a dorsal portion, the M. axillary process, which extends forward beneath the region of the eye and gives rise to the maxilla, the zygomatic bone, and part OF the temporal bone, Fig. 7. The ventral portion, the M. mandibular process, contains the mechal cartilage. Mesenchyme around the mechal cartilage condenses and ossifies by intramembranous ossification to give rise to the mandible. The mechal cartilage disappears except in the sphenomandibular ligament. The dorsal tip of the mandibular process, along with that of the second pharyngeal arch, later gives rise to the incus, the M. malleus, and the stapes, Fig. 7. Ossification of the three ossicles begins in the fourth month, making these the first bones to become fully ossified. Mesenchyme for formation of the bones of the face is derived from neural crest cells, including the nasal and lacrimal bones, Fig. 4. At first, the face is small in comparison with the neurocranium. This appearance is caused by 1. Virtual absence of the paranasal air sinuses. 2. The small size of the bones, particularly the jaws. With the appearance of teeth and development of the air sinuses, the face loses its babyish characteristics. Clinical correlates, craniofacial defects and skeletal dysplasias. Neural crest cells. Neural crest cells originating in the neuroectoderm form the facial skeleton and part of the skull. These cells also constitute a vulnerable population as they leave the neuroectoderm. They are often a target for teratogens. Therefore, it is not surprising that craniofacial abnormalities are common birth defects. Cranioschisis. In some cases, the craniolar vault fails to form, cranioschisis, and brain tissue exposed to amniotic fluid degenerates, resulting in anencephaly. Cranioschisis is caused by failure of the craniolar neuropore to close, Fig. 8a. Children with such severe skull and brain defects cannot survive. Children with relatively small defects in the skull through which meninges and or brain tissue herniate, cranial meningocele and meningoencephalocele, respectively Fig. 8s may be treated successfully. In such cases, the extent of neurological deficits depends on the amount of damage to brain tissue. Craniosynostosis. Another important category of cranial abnormalities is caused by premature closure of one or more sutures. These abnormalities are collectively known as craniosynostosis, which occurs in 1 in 2,500 births and is a feature of more than 100 genetic syndromes. Regulation of suture growth and closure is not well understood but may involve interactions between neural crest and mesoderm cell boundaries. For example, crest cells form the frontal bones, whereas paraxial mesoderm forms the parietal bones and the loose mesenchyme in the coronal sutures. AISO, crest cells migrate between the parietal bones and form the first part of the sagittal suture. Molecular signaling at these boundaries regulates cell proliferation and differentiation. For example, EFNB1 encodes FRNBI, a ligand for FB receptors that causes cells to repel each other, a kind of anti-adhesive activity and important for preventing premature suture closure. Loss of function mutations in EFNB1 causes craniofrontonasal syndrome, characterized by coronal suture synostosis and hypertelorism. Proliferation of neural crest cells in the frontal bones is regulated in part by the transcription factors MSX2 and twisty THAT act cooperatively in parallel pathways. Mutations in MSX2 cause Boston-type craniosynostosis that can affect a number of sutures, whereas mutations in twisty cause Sethra-Shotson syndrome, characterized by coronal suture synostosis and polydactyly. Fibroblast growth factors, FGFs, and fibroblast growth factor receptors, FGFRs play important roles in most of skeletal development. There are many members of the FGF family and their receptors. Together, they regulate cellular events, including proliferation, differentiation, and migration. Signaling is mediated by the receptors, which are transmembrane tyrosine kinase receptors, each of which has 3 extracellular immunoglobulin domains, a transmembrane segment, and a cytoplasm isterosine kinase domain. FGFRL and FGFR2 are co-expressed in prebone and precartilage regions, including craniofacial structures. FGFRS is expressed in the cartilage growth plates of long bones and in the occipital region. In general, FGFR2 increases proliferation, and FGFRL promotes osteogenic differentiation, whereas the role of FGFRS is unclear. Mutations in these receptors, which often involve only a single amino acid substitution, have been linked to specific types of craniosynostosis FGFRL, FGFR2, and FGFRS and several forms of skeletal dysplasia FGFRS. Table point 1. The shape of the skull depends on which of the sutures closes prematurely. Early closure of the sagittal suture 57% of cases results in frontal and occipital expansion, and the skull becomes long and narrow, scaphocephaly Fig 9. Premature closure of the coronal sutures, 20% to 25% of cases results in a short skull called brachycephaly Fig 14. If the coronal sutures close prematurely on one side only, then the result is an asymmetric flattening of the skull called plaglocephaly Fig. 10 BC. By far the most common causes of craniosynostosis are genetic. Table 1. Other causes include vitamin D deficiency, exposure to teratogens, including diphenylhydrogen, retinoids, valproic acid, methotrexate, and cyclophosphamide, and intrauterine factors that constrain the fetus, such as oligohydramnios and multiple birth pregnancies. Skeletal dysplasias. Achondroplasia, ACH, the most common form of skeletal dysplasia 1/20,000 live births, primarily affects the long bones Fig. 11a. Other skeletal defects include a large skull megalocephaly with a small midface, short fingers, and accentuated spinal curvature. ACH is inherited as an autosomal dominant, and 90% of cases appear sporadically due to new mutations. Thanatophoric dysplasia is the most common neonatal lethal form of skeletal dysplasia 1/40,000 live births. There are 2 types, both are autosomal dominant. Type I is characterized by short, curved femurs with or without cloverleaf skull. Type 2 individuals have straight, relatively long femurs and severe cloverleaf skull caused by craniosynostosis Fig. 12. Another term for cloverleaf skull is Kleeblatt-Chaudel. It occurs when all of the sutures close prematurely, resulting in the brain growing through the anterior and sphenoid fontanelles. Hypochondroplasia, another autosomal dominant form of skeletal dysplasia, appears to be a milder type of ACH. Common to all of these forms of skeletal dysplasias are mutations in FGFRS causing abnormal endochondral bone formation, so that growth of the long bones and the base of the skull are adversely affected. Generalized skeletal dysplasia. Cleidocranial dysostosis is an example of a generalized dysplasia of osseous and dental tissues that is characterized by late closure of the fontanelles and decreased mineralization of the cranial sutures, resulting in bossing in large end of the frontal, parietal, and occipital bones. Other parts of the skeleton are affected as well, and oftentimes the clavicles are underdeveloped or missing. Acromegaly. Acromegaly is caused by congenital hyperpituitarism and excessive production of growth hormone. It is characterized by disproportional enlargement of the face, hands, and feet. Sometimes, it causes more symmetrical excessive growth and gigantism. Microcephaly. Microcephaly is usually an abnormality in which the brain fails to grow and, as a result, the skull fails to expand. Fig. 14. Many children with microcephaly are severely intellectually disabled. Vertebrae and the vertebral column. Vertebrae form from the sclerotome portions of the somites, which are derived from paraxial mesoderm. Fig. 15a. A typical vertebra consists of a vertebral arch and foramen, through which the spinal cord passes, a body, transverse processes, and usually a spinous process, Fig. 15. During the fourth week, sclerotome cells migrate around the spinal cord and notochord to merge with cells from the opposing somite on the other side of the neural tube, Fig. 15a. As development continues, the sclerotome portion of each somite also undergoes a process called resegmentation. Resegmentation occurs when the caudal half of each sclerotome grows into and fuses with the cephalic half of each subjacent sclerotome arrows in Fig. 16ab, thus, each vertebra is formed from the combination of the caudal half of one somite and the cranial half of its neighbor. As a result of this process, muscles derived from the myotome region of each somite become attached to two adjacent somites across the intervertebral discs and can therefore move the vertebral column. Patterning of the shapes of the different vertebrae is regulated by HOX genes. Mesenchymal cells between cephalic and caudal parts of the original sclerotome segment do not proliferate but fill the space between two precartilaginous vertebral bodies. In this way, they contribute to formation of the intervertebral disc, Fig. I0.16b, although the notochord regresses entirely in the region of the vertebral bodies, it persists and enlarges in the region of the intervertebral disc. Here it contributes to the nucleus pulposus, which is later surrounded by circular fibers of the annulus fibrosus. Combined, these two structures form the intervertebral disc, Fig. 16c. Resegmentation of sclerotomes into definitive vertebrae causes the myotomes to bridge the intervertebral discs, and this alteration gives them the capacity to move the spine, Fig. 16c. For the same reason, intersegmental arteries, at first lying between the sclerotomes, now pass midway over the vertebral bodies. Spinal nerves, however, come to lie near the intervertebral discs and leave the vertebral column through the intervertebral foramina. As the vertebrae form, two primary curves of the spine are established, the thoracic and sacral curvatures. Later, two secondary curves are established, the cervical curvature, as the child learns to hold up his or her head, and the lumbar curvature, which forms when the child learns to walk. Clinical correlates, vertebral defects. The process of formation and rearrangement of segmental sclerotomes into definitive vertebrae is complicated, and it is fairly common to have two successive vertebrae fuse asymmetrically or have half a vertebra missing, a cause of scoliosis, lateral curving of the spine. Also, the number of vertebrae is frequently more or less than the norm. In Klippel-Fehl sequence, the cervical vertebrae are fused, causing reduced mobility and a short neck. One of the most serious vertebral defects is the result of imperfect fusion or non-union of the vertebral arches. Such an abnormality, known as cleft vertebra, spina bifida, may involve only the bony vertebral arches, leaving the spinal cord intact. In these cases, the bony defect is covered by skin, and no neurological deficits occur, spina bifida occulta. A more severe abnormality is spina bifida cystica, in which the neural tube fails to close, vertebral arches fail to form, and neural tissue is exposed. Any neurological deficits depend on the level and extent of the lesion, Fig. 17. This defect, which occurs in 1 per 2,500 births, may be prevented, in many cases, by providing mothers with folic acid prior to conception. Spina bifida can be detected prenatally by ultrasound, and if neural tissue is exposed, amniocentesis can detect elevated levels of folic 2 protein in the amniotic fluid. Ribs and sternum. The bony portion of each rib is derived from sclerotome cells that remain in the paraxial mesoderm and that grow out from the costal processes of thoracic vertebrae. Costal cartilages are formed by sclerotome cells that migrate across the lateral somitic frontier into the adjacent lateral piate mesoderm. The sternum develops independently in the parietal layer of lateral plate mesoderm in the ventral body wall. Two sternal bands are formed in the parietal, somatic, layer of lateral plate mesoderm on either side of the midline, and these later fuse to form cartilaginous models of the manubrium, sternebrae, and xiphoid process. Clinical correlates, rib defects. Occasionally, extra ribs are formed, usually in the lumbar or cervical regions. Cervical ribs occur in approximately 1% of the population and are usually attached to the 7th cervical vertebra. Because of its location, this type of rib may impinge on the brachial plexus or the subclavian artery, resulting in varying degrees of anesthesia in the limb. Defects of the sternum. Cleft sternum is a very rare defect and may be complete or located at either end of the sternum. Thoracic organs are covered only by skin and soft tissue. The defect arises when the sternal bands fail to grow together in the midline. Hypoplastic ossification centers and premature fusion of sternal segments also occur, particularly in infants with congenital heart defects, 20% to 50%. Multiple menubrial ossification centers occur in 6% to 20% of all children but are especially common in those with Down syndrome. Pectious excavatum is the term for a depressed sternum that is sunken posteriorly. Pectus carinatum refers to a flattening of the chest bilaterally with an anteriorly projecting sternum. The projection of the sternum resembles the keel of a boat. Both defects may result from abnormalities of ventral body wall closure or formation of the costal cartilages and sternum. Plus summary, the skeletal system develops from mesenchyme, which is derived from the mesodermal germ layer and from the neural crest. Some bones, such as the flat bones of the skull, undergo intramembranous ossification, that is, mesenchyme cells are directly transformed into osteoblasts, Fig. 2. In most bones, such as the long bones of the limbs, mesenchyme condenses and forms hyaline cartilage models of bones, Fig. 3. Ossification centers appear in these cartilage models, and the bone gradually ossifies by endochondral ossification. The skull consists of the neurocranium and the viscerocranium, face. The neurocranium includes a membranous portion, which forms the cranial vault, and a cartilaginous portion, the chondrocranium, which forms the base of the skull. Neural crest cells form the face, part of the cranial vault, and the precordial part of the chondrocranium, the part that lies rostral to the pituitary gland. Paraxial mesoderm forms the remainder of the skull. The vertebral column and ribs develop from the sclerotome compartments of the somites, and the sternum is derived from mesoderm in the ventral body wall. A definitive vertebra is formed by condensation of the caudal half of one sclerotome and fusion with the cranial half of the subjacent sclerotome, Fig. 16. The many abnormalities of the skeletal system include vertebral, spina bifida, cranial, cranioschisis and craniosynostosis, and facial, cleft palate, defects. Major malformations of the limbs are rare, but defects of the radius and digits are often associated with other abnormalities, syndromes.